Hey, everybody. Welcome to In the Know with Nina. I'm your host, Dr. Nina Crowley. I'm the Director of Clinical Education and Partnerships at SICA, where we partner with healthcare professionals and clinicians to offer body composition solutions. Today, I'm excited to be joined by Melissa Mitri. She's a registered dietitian and weight loss expert and a freelance writer. And we're going to talk about all the things nutrition around medication, incretin-based therapies, AOMs, GLP-1s, lots of different words and language for what we're going to talk about today, but I'm really excited to have you on and have your expertise.
Hey, Nina, thank you so much for having me. I'm excited to be here.
Great. Well, yeah. So I know you've been in the field a while as a dietitian. You've been practicing with patients who had bariatric surgery and now in the medication space. So it's been a fun time, hasn't it?
Yeah, absolutely. A lot has changed since I've started. I've been in the field for over 18 years, but come a long way. And yeah, there's this with the new medications, it's really changed the landscape and really for the better. So
Absolutely. And there's so much to decipher that's a little bit different than it was with surgery or before we had, different treatments for the disease state of obesity. But here, I think nutrition has really become, more and more important for the long term, as we've known for
mhm.
obesity as a disease. But I thought we could kind of dive in and talk about, in terms of nutrition, I think the meal timing and spacing and scheduling is a big thing that we focus on. Where is protein fitting in? How do we maximize nutrition? In my world now, I care a lot about, making sure we're looking at body composition to be, part of this advanced comprehensive obesity care. And then I think we always need to talk a little bit about sort of nutrition with side effects and how do we manage that and really how often is that a factor for patients, right?
hmm Absolutely. No, I think that when it comes to these medications, everyone is going to respond to them differently, of course. And so keeping that, kind of in the back of all of our minds, I think is really important. But the timing and what and when you eat it, it really matters. It can really make a big difference in terms of maximizing results on these medications and helping our patients to just feel better, to be able to stay on them to achieve those results.
I think something that we talk about, that you and I talked a little bit about before we hit record, is how we're framing sort of the guidelines with patients too. I think there's sort of this lots of discussion now about, do we consider being on medications long term? Do we hope to get off of them? There's a lot of talk about discontinuing, demedicating, microdosing. One of the things that I feel pretty strongly about is if we're really talking about obesity as a disease and needing chronic treatment for life of that chronic disease, we can specify, changes in dosage and treatment types and all of that. But I think considering really that long-term treatment as a long-term relationship that you have with a patient, and you'll try different things, I think that's very important. So that we're almost saying the instead of treating them as an exception to the rule, we should maybe treat everybody as the rule, like that you're going to be with these treatment modalities long term. And if you're able to personalize and get off and change, like there always are, of course, exceptions. As you said, there's non-responders. There's people who, have a tremendous response early and remain on a very low dose medication. There's also people who get all the way to the highest dose and don't see those same responses. I just think behaviorally, psychologically, we want to put the message out that everybody might have a different response, because what if you're that patient who doesn't have a great response and if you're a consumer of the media, you're seeing the weight's melting off of everybody. There's a lot of
Mhm.
messaging around it being so easy. And so I'd
Right.
imagine for people who it's not having that experience, that's especially tricky.
Absolutely. I completely agree with that. And I see that a lot in my own practice because I've had patients and clients that are on these medications and they don't always see the success that they're seeing either their friends are having or those on social media are having. Because I think when it comes to social media too, right, like everybody's sharing their successes. They're really not always sharing the negatives. And so what our patients are seeing is seeing all the success. And so it can make them feel defeated. Well, why is this not working for me if I'm doing all of these same things? But when we compare one person to the next, that one diet, there's not one diet or way of eating that works for everyone, and there's not one treatment medication modality that's going to work for everyone. And keeping that in mind too, if you have patients that are are the non-responders, that doesn't mean that they're not going to respond well to another medication. And so there are always other options. There are other medications, there's surgery. And as you said, obesity is a disease. And so it, just like other disease states, it requires some trial and error to
Mm,
figure out sort of the best overall comprehensive treatment plan, right? Not just the medication, but also the right lifestyle factors, the right diet and exercise plan for that particular patient that's going to work for them long term. So the goal being that they are, hopefully able to stay on these medications, because when the research does show that a majority of the people do gain the weight back, even if they are doing all of the right things, because you're taking away that medication that's really treating that underlying
yeah.
problem. So,
Yeah, the biology piece is huge here.
mhm.
Um, okay, well, let's dig in a little to the nutrition stuff. So when it comes to kind of the when and the timing, what I've heard a lot is patients who, when you see that reduction in appetite, right? A lot of times people are like, "Oh, great! I've had such hunger for so long. I'm very excited not to have that. So I'm not going to eat if I'm not hungry, right?" And so then they may go all day without eating, and that makes it tough to get in enough nutrition at the end of the day. So how do you talk to patients about that? How do you reconcile that?
Yeah. So in terms of meal timing, I think it's really important to think about that the timing of meals is likely going to be different in terms of what the person may be used to. So many people are typically eating 2 to 3 meals a day on average. And with these medications, the ideal is to try to slowly move into more of a 4 to 5 smaller meals per day, which again, it may not feel natural at first to the patient, especially if their appetite is very much suppressed. And so it's kind of starting small. And that's why it could feel more manageable, because the patient is not feeling like they're forcing a large meal when they're not feeling up to eating. And so even if they are not feeling hungry, they still should be having something. And I know that I've seen this a lot of my clients when they first start on these medications, that they are skipping meals, or that they're not having breakfast and they're waiting until 2, 3 o'clock to eat. And then when that happens, then they're not able to get in enough nutrition or enough protein, especially by the end of the day, which is a problem, which we'll talk about. And so really just trying to, something that I often recommend to do for my patients is just set like a suggested meal schedule for them. So a registered dietitian can do this, and knowing that, where you kind of just break it up for the patient, a suggested schedule, and they don't have to follow it to a T, but maybe starting with some easier to digest foods if they are having and experiencing any side effects. I found in a lot of my patients that starting out with more of like a liquid based meal, especially in the morning, can be really helpful. That's the time that often they feel the least hungry. And so just some little things like that, again, individualized depending on the patient. But really breaking it up into those more kind of like, larger snacks, almost like, or smaller meals throughout the day, is just going to feel more manageable for the patient, to be able to, at the end of the day, meet their nutrition goals.
I like that. And I think one of the things that's so exciting about the biology and the appetite piece is that the medication is taking care of something that, without medication, we've long relied on patients to sort of have to tackle themselves. When do I
Hmm.
eat and how much do I eat? And so I think of it more like your body's actually going to probably tell you more when you're full, and you're going to be able to tune into that cue a little bit better. So
Hmm.
it's your sort of role then is to make sure that the things that you have available to have a few bites of are good quality, are nutritious, are the things that you want to include. And the amount or how many bites or the volume, that's a little bit less important because now your biology does that. And that, I mean,
Hmm.
that's very, very much the same counseling we did with the surgical patients, where
Hmm.
they know right away when they're feeling full. So it's less
Right.
important that they're eating some of these foods that they may have thought all their life, like these diet foods, right? Or, oh, I need to eat this exact perfect lean cut of this or that. It's like,
Hmm.
you need to have good stuff that you like, that's high quality, and a few bites, you're going to feel full. So it's a completely different conversation
It
than,
is.
this. I always had patients picturing this like 3 ounces of grilled chicken with a couple spears of broccoli and some brown rice on the side. Like that doesn't have to be the way they eat. Very
Right.
few, I mean, I don't eat like that. There's very few people I
Hmm.
know that eat
Right.
like
It's
that.
not really sustainable. Yeah.
So,
Yeah. Absolutely. I completely agree. And definitely kind of driving it back to the bariatric patients. I mean, really a lot of the recommendations and the way, what we're recommending to patients on GLP-1s is related to the bariatric patients because it is a similar sort of schedule and there's similar potential side effects that patients may experience as they would after a bariatric surgery. And so it is, kind of a lot of the recommendations are based on that because if you think about someone that is getting full, it has that early satiety very quickly, then as you said, it's just having a few small bites. And that's why everything that they are eating, or the majority of what they're eating should be of high quality so that, they're really kind of just maximizing what they are taking in. And again, it is different than what they may be used to. So kind of helping them to change that mindset too, and just focus on quality rather than counting calories necessarily, because they're reducing the calories is going to feel much easier when the medications are controlling their appetite.
Do you have any thoughts on, some of these new, like, I just have seen so much in the food industry side, right? Of like products that are labeled with GLP-1 or,
Mm-hmm.
it's a whole different, kind of space. Do you have any thoughts on those or how do people, I'm sure people are asking you a lot about them. How do you
Oh
fit
yeah.
those in?
Yeah, so there's these like supplements, they're called GLP-1 activators. And so they are basically supplements, ranging from anything from probiotics to different types of fibers. Berberine is another one, which is often, a supplement given to those with diabetes to lower blood sugar. And so all of these really, from what I've seen, I've done research on them and my patients have asked me, very modest effect in reducing appetite, nothing in comparison to the GLP-1 medications.
Right.
And so they're out there. I think they're going to continue to be out there just as, of course, for marketing purposes. But, what they claim it to naturally increase GLP levels in the body. And so they work, differently in that way. It kind of goes back to even, if you think about fiber as an example, a fiber supplement may do the same thing as eating fiber, eating a high fiber food, that it does help to make you full. It might promote some early satiety, but it's very short lived in comparison to the medications, where it's lasting for 5 to 7 days until the next injection. And versus the foods and supplements, it's just going to last for about an hour or so.
I'm even thinking too, like the different food products that are promoted that way. So, like, protein
Mm-hmm.
enhanced stuff. I think, and I know you wrote a recent article, all about protein. I thought that was really interesting too. So, like, we're
Mm-hmm.
definitely seemingly in this era of protein is king, right? Everybody's trying to, get more. So,
Mm-hmm.
um, beyond products there too, but like how much protein are we recommending for these folks?
Yeah, so I think there should be an emphasis on protein, but sometimes it's almost pushed a little bit too far. With those on GLP-1s and just for people for weight loss in general. But the recommendation, to date is about 1.2 to 1.5 grams per kilogram of protein, and that's for ideal body weight. And so, if you look on social media on influencers and kind of everywhere you look, you'll see different recommendations. So knowing that there's going to be other recommendations out there, but what we're basing these recommendations on now is on bariatric patients and what has been seen to be based on evidence to really preserve muscle mass as a patient loses weight, because especially for those that are losing weight kind of more rapidly on these medications. So what rapidly would be anywhere from like, above 3 to 4 pounds of weight loss per week. And so there is more of a risk of muscle loss. And so that's where these guidelines sort of stem from, above the RDA of zero point 0.8 grams per kilogram,
Right.
because that's really kind of just the bare minimum for health. But we need more. These patients need more to preserve muscle mass and ideally to build muscle to just preserve a healthy metabolism long term.
So I always laugh about how, we as dietitians are always talking about kilograms per kilogram, right? Like I'm forgetting the
Yeah.
math there too, but like, what does that equal? So if we're saying ideal body weight, for somebody, what does that end up being in like grams per day or amount, kind of in the real food way that people eat? less
Yeah.
painful.
Yes, exactly. So it ends up being usually around like anywhere from like 80 to 120 grams per day of protein on average. So depending on the person's weight. But yeah, so that would be the recommendation. And so, we kind of think about how to break it up between meals, if for someone that's eating, again, four to six small meals a day or so, then, maybe 10 to 15 grams, maybe 20 grams at most at each meal versus, kind of promoting that, 30, 35 grams per meal, which may be too much for someone that's really having that early satiety. And they really, that higher amount per meal is really meant for someone that's not on a GLP-1 that really needs that added early satiety. For someone that's on a GLP-1, they're going to want to break it up into smaller portions.
It's a tricky balance, right? Because,
Hmm.
yeah, I mean, I always remember like high protein, high fiber was really the basis of a lot of, eating with bariatric surgery to stay full on small amounts of food. And here we're saying, that maybe that isn't the number one focus anymore because they're already feeling full on small amounts of food too.
Hmm.
Um, but getting that much, again, I'm trying to translate that into like, what is it? 3 ounces of chicken is like what, 20 grams of
About
protein.
21 grams. Yeah. Hmm.
So, I
Yep.
mean, that could be a reasonable amount to eat and get full from, balancing it out with some veggies and stuff.
Hmm. Yes.
But yeah,
Yes.
I think that's, this is reminding me of what I used to do, and just sometimes taking that math and translating that into like what that physically looks like. And because
Hmm.
people aren't eating grams, they're eating the
Right.
food items. And so
Right.
how does that look to something that they like and want and, can sort of achieve? I think that's, I mean,
Yeah.
maybe again, back to what the value of a dietitian is on their team,
Hmm.
'Cause I think
Right.
people also tend to really, they do tend to view protein as this, like they think of protein sometimes as a food group, right? Or
Hmm.
like how much
Yeah.
protein you're getting, but you have to like cook it, eat it,
Hmm.
enjoy it, digest it. And so,
Right, exactly. It should taste good. It doesn't have to be the boring grilled chicken.
right.
So, yeah, so I think, it's thinking about it again from making it simplified, like you said, and having visuals. A lot of times, as a dietitian, I'm recommending, like I have, a tip sheet that has visuals of common portion sizes that kind of like, that could be a good starting point for patients. Other patients like to just weigh their proteins and they, in the beginning. And so again, everybody's going to be a little bit different depending on the tools that they have and that they're willing to use. But there's always helpful visuals that can give them as examples. And then even there's a lot of ways you could sneak in that protein if they're not able to even have 3 ounces of protein at one time, or, you could sneak in a little like seeds or nuts, or in a breading of a chick, a piece of chicken, for example, or even like something like a Greek yogurt. Anything that has a higher amount of protein in a smaller portion can be the most helpful. And a lot of times that ends up being more like animal based proteins. So I think someone who is a vegetarian, it could be a little bit more of a little trickier, but not impossible. Just need to kind of find the highest quality plant-based proteins that don't cause any side effects. So maybe, something like a tofu versus, too many beans might be a little bit more,
Mhm.
difficult to digest.
Yeah, and that, that kind of does lead me to talk a little bit about side effects too, because I think it's just
Hmm.
reminding me of working with like pregnant women who often, when they're feeling nauseous, the foods that they don't want to eat are those, bigger, thicker animal proteins that they have to sort of chew and digest and that we want for satiety.
Hmm.
If it's sitting in the stomach longer, which is usually why we want that for satiety, that might not feel good if they're prone to nausea.
Hmm. Absolutely. Yeah. So definitely limiting the higher fat meats, the saturated fat that's in a lot of, animal proteins, cheeses, et cetera, has shown to be a little bit more bothersome than even like the healthier fats from avocados, for example. So it's not even necessarily just too much fat in general, but more the types of fats. So definitely, and I've seen this firsthand with my clients, like any type of even if it's a chicken breast, but it's fried, where it's like chicken tenders versus just like a grilled chicken, can be much more
Mhm.
bothersome to the gut, where it just causes a lot of, bloat. It may cause more nausea, especially. So nausea is definitely one of the most common GI side effects that we see, and that's shown in the research too. So anything that's high in fat, like, again, fried foods, red meat, heavy sauces, cream sauces, etc., can definitely be bothersome for a lot of the side effects
Okay.
that may come. So, and then yeah, there's a lot of again, this is individualized depending on the patient, but even just starting with that, if we think about kind of the progression of what we're recommending for patients, it's like starting with the meal timing first and that schedule that we talked about, because that alone, the small frequent meals might sort of alleviate some of those potential side
Right.
effects like nausea, diarrhea, bloatedness, etc., and fatigue. Fatigue is another common side effect that I see is not always talked about as much as the gastrointestinal side effects,
Mm.
but I see it a lot, and is another common one. A lot stemming from patients that may be skipping meals because they're not on a good schedule, or patients may have low blood sugar, hypoglycemia, because they're on a GLP-1, which is, remember, these GLP-1s, a lot of them were originally diabetes medications. And then for someone who doesn't have diabetes and then maybe is eating very little, then hypoglycemia can also be a potential
Right.
concern. So kind of, having those small frequent meals and focusing on lowering the fat intake, being careful with fiber. Because when we talked about fiber, protein and fiber really are those two most important nutrients that we think about when we think about weight loss and satiety and all of those things. But we don't want to recommend increasing fiber too quickly,
Mm.
because in a patient that's not used to eating a lot of fiber from fruits and vegetables and whole grains, and then they all of a sudden start eating the recommended 25 to 35 grams per day, that can be a lot on the gut, especially with that early satiety already. So kind of starting with increasing fiber gradually, and that's going to look different depending on what their side effects are. If somebody, for example, is having diarrhea, then you're going to want to be more careful with the insoluble fiber, which is in more of like the leafy greens, those types of foods. And then maybe the soluble fiber from oatmeal, for example, is going to be a better choice during that time because it's going to
Mm.
help to bulk up the stool.
Right. Yeah, all of this is, it kind of highlights to me again how important it is to personalize, and how there's so much out there of just generalizing it. Like, these are the GLP-1, kind of pathways or foods or items. And
Hmm.
it's like, all the foods could work to some
Hmm.
extent. It just matters, how the person feels, what they like, what they're interested in, what, is available to them. That's a big one. And then how they feel on it, you
Right,
know? So
right,
it
exactly.
again reminds me how important dietitians and a comprehensive care team are to really
Yeah.
helping that person. And it's not like what you eat today is going to be the same types of things that you're eating in 6 months. It's constantly
Hmm.
evolving.
Exactly. It's constantly changing. I'm glad you mentioned that because I was going to say like how a lot of the side effects from especially the gastrointestinal side effects are usually transient. They usually are
Mm.
more in those first 4 to 8 weeks. That's the most common period of time as the patient's medication dose is being titrated up. And then usually around the 8 week mark, it starts to settle where those symptoms improve. And so a lot of these recommendations to modify the types of foods, or increase certain foods, decrease others, it may change over time. And that's why that consistent follow-up is important, that the dietitian working with the physician. And I know that I've been hearing from a lot of my patients too, in terms of increasing the dose every 4 weeks, that they're not always increasing every 4 weeks just automatically now anymore. We're in the beginning stages. That was kind of like protocol. But
Mm.
now there a lot of the prescribing physicians, at least some of my patients are telling me, is that they're basing it more on how they feel, so and the results. So if they find kind of a middle ground where patients are continuing to lose weight, they have a decreased appetite, but they're still enjoying their food, that is more kind of the overarching goal versus going at the highest dose and really not enjoying food at all and having such a low appetite that they're not able to get in enough. And so I'm
Yeah.
really glad to start seeing that happening too.
It sounds like there's a sweet spot, and everybody's is different. And,
Hmm.
you've really got to have lots of people on the team to sort of have these conversations too.
Yeah, absolutely. Because it's like you said, it's different depending on every patient, and it may change, from month to month. And, so kind of navigating that process, weight management is a lifelong process, regardless if somebody is taking a GLP-1 or not. And so there's tweaks that often just need to be made over time, depending on how the patient is doing.
Yeah, well, definitely lots to consider. I do really feel like the ability for medication to take appetite, which for so long has been, for many patients, the big struggle.
Hmm.
How do you see patients kind of responding to the concept around food noise and how the medications are able to reduce, all that incessant thinking about and sort of perseverating about food and eating and planning and all of that? Do you see that a
Hmm.
lot? Do you talk about that a lot?
Yeah, definitely. That's something that I see very often. Almost all of my patients that are taking GLP-1, that food noise is really dialed down, and in a good way. And so again, it's just kind of managing. Well, I always check with them to see, are you still enjoying your food? Like, does the food still taste good? Again, it's that balance. But I definitely see that in the majority of the patients that are taking these medications, that their food noise is very much suppressed, and it's hugely helpful because they're able to kind of think more of food as still as enjoyment, but more as fuel, and not this, like, really taking over their life, and that they're all, thinking about it so much. So it's really huge in doing that, and I think that's one of the ways where it's so effective, because, like you said, I mean, a lot of times, when somebody is not taking one of these medications, they could be trying to do all the right things, and they're not seeing the success, because especially as they lose weight, those hunger hormones come back, and they come back with a vengeance, and the body just keeps trying to fight to get them back to that previous weight. And that's really hard for that person to do when they're really trying to kind of muster up all of this willpower. And so, the GLP-1s really help so much with that, getting to that, like, underlying physiology.
Yeah, I think of it, almost for dietitians in this space, it's like it's kind of the dream, right? Because a lot of our patients have been, but many have struggled with their weight their whole life and they've tried all the different things. So they actually really have a lot of knowledge. I think sometimes we forget that,
Yes.
or maybe we don't, but the the media forgets that, and
Hmm.
so the thing that I've seen the most is it's able to help people get rid of those problematic thoughts that get in the way, the appetite that for many, that is the issue. I mean, everybody is so
Hmm.
different, but these are generals,
Hmm.
takes away these sort of things that have always gotten in the way, and it frees them up to do the stuff that they've either always known, always wanted to do, or maybe always been doing, but just had other things getting in the way. So I think it's a
Right.
very liberating experience for people. And I've even
Yes.
heard some talk about how, regardless of the weight outcome or the body composition change outcome or whatever we're looking at,
Hmm.
some people may want to continue on them for the mental behavioral side effects like reduction in food noise and all of that. So, like, even if they're not seeing a change in their weight,
Hmm.
that's an
Right.
impact that we should be looking at. So it also gives us another thought about what should we be monitoring or measuring, quote, success on,
Hmm. Hmm.
and that's always
Yeah.
a tough one.
Yes, absolutely. No, that's a great point, though. I've seen that a lot of my clients too, or even if they've, a lot of these patients, they may not always be getting to their ideal weight necessarily either. Or maybe they lose a small amount of weight and then they plateau, and then we kind of reassess and see what it is, what are their new goals. But really the goal is health, right? These medications, they help improve health. Obesity is a disease. And so I know that, a lot of new benefits of these medications are coming out alone, separate, even entirely separate from the weight loss itself. And so, but when we think about, I always focus also on the non-scale victories, and these other victories other than just what's changing on the scale, but like what is going on inside their body, like what is, their body composition like. And that's why we focus on the habits more than anything, to promote muscle mass and preserve that, because that's what's going to help them maintain the weight that they lost in the long term and improve their health. Because if they're losing a ton of weight, but they're losing a lot of muscle, and they're not really focused on the long term habits, then that's just, kind of feeding into that yo-yo weight cycling that, people really don't want. They want a sustainable solution. And so one thing that I always have my patients do, and track, there's a lot of things we track, of course, but tracking the body composition in some way where when they're weighing themselves, either if they may have a scale that they use at home that tracks their body composition, but I always encourage them to try to do that in their doctor's office where they have that more reliable scale, like a Sika scale that, really has much less, really much more accurate, where those body composition scales at home are convenient, but there's a much larger room for error. They're not quite as accurate. So it's a good starting point, but I always have them track in some sort of way where they can be able to see what's happening inside their body, because that gives them motivation too, right? Like even if they're not seeing a change in their actual weight in a given week or month, they're seeing the body composition changes, which is really a more accurate measure of how they're doing.
Totally. And I also think, the way you're saying that too at home, they don't get to go home with a dietitian, right? So someone to
Right.
help them. I mean, there's a lot around weighing practices and body composition measurement too, where people have reactions that are emotional, and that, it's not something we recommend doing every day. We, want to do it only when we can see a measurable, significant change,
Right.
because people can really derail by just focusing on this outcome and not sort of translating that back into the behavior change that they're working so hard on. I just
Yep.
remember so many times seeing like an hour-long session with someone where we did some really amazing work, get kind of derailed by then they look at the number, or they, kind of see, oh, well, that in their head, they had an equation of how much effort they were willing to do to get a certain outcome. And when that doesn't, get met, it's like, well, why am I even doing this?
Right.
So
Right.
I do think it's a special balance of, how frequently you're looking at that, and that you have
Yes.
someone trained in how to have, sort of those conversations around what does that mean and how do we use
Right.
it in a motivating way, like you said, rather than you know, or demotivating way, or just
Right.
a, thing that we
Yes.
hyper focus on and perseverate on.
Yes, I completely agree, because there's a lot of patients that are still, wanting to weigh themselves every day. And so, as you said, you're not going to see, you're not going to see any measurable changes in doing that every day, and especially the body composition piece, which takes longer to see. And so I often recommend that, if they're weighing themselves even once a week, take those results with a grain of salt, that it should be more, at least on like a month to month basis, to really be able to see those changes in percentages of muscle mass and body fat percentage and all of those things that, we're tracking. And like you said, having someone who is skilled to be able to decipher those results for them too, when they're seeing that, so that they understand what everything means.
Right.
And like you said, if they see something's in the red, then they don't feel discouraged, that it's okay. Okay, this is what we're seeing now, but again, it's a gradual process, and this is what we can do now to improve those specific measurements.
Yeah. Well, this is confirming that I don't think AI can fully take over our jobs just yet. It seems like all of
Yeah,
the
no.
all of the nuance to counseling and supporting people with the disease of obesity is really still going to be relevant, throughout this treatment phase too.
Yes, I completely agree.
Well, thank you so much for your time today. This is a really great discussion. It's, I think
Sure.
a lot of new tips, a lot of confirming that we need to, be vocal about support for patients, comprehensive care,
Hmm.
advanced advanced care for people with obesity. So,
Yeah,
um,
absolutely.
yeah. So, well, how do we connect with you, or if people want to stay connected, or follow you on social?
Yeah, so I'm on LinkedIn. I'm very active on LinkedIn, Melissa Mitri. So it's Mitri. And also you can find me on my website, melissamitri.com. And then I also want to share, I do have a resource kind of to couple from our conversation today. It's a GLP-1 cheat sheet for healthcare professionals. So I
Oh,
do,
okay.
I think that I had sent you the link. If not, I'll make sure to do that, maybe in the show notes. But it's really just a nice, tangible resource that providers can use. Medical providers and registered dietitians can use in their practice to,
Awesome.
just have a good tangible resource that that explains how the GLP-1s work, what are some of the biggest recommendations that they can share with patients, so that they can kind of use that as a guide during their
I love
counseling
that.
sessions.
Awesome. Okay. Well, we'll
Oh,
put that in the notes to make sure everybody grabs that.
sure.
And can't wait to see you at our next in-person conference and stay connected
Yes.
on LinkedIn.
Same here. Thanks so much, Nina.
All right. Have a good one.
You too. Bye.